Okay, welcome along everyone. Thank you for joining today's presentation. My name is Sam Levy. I'm the Coding Improvement Manager at Manchester University Foundation Trust. Our trust is one of the biggest in the country, and our coding department has around 90 members of staff. So I've been asked to come and speak to you all today about what clinical coding is and what it means in terms of finance, and as the title of the presentation, being paid for our services, what role coding plays in that. I'll just drop a quick apology in as well. I am full of a cold, so I'm sorry if I do sound a little bit nasally, but undeterred, we will continue. So what is clinical coding? And it's a question that gets asked an awful lot, and the answer isn't particularly helpful. And there's usually two categories of people that get that question. So it's friends and family, or people that you meet and you say, what do you do? And say, I work in clinical coding. And they go, ooh, that sounds very interesting, tell me about it. And you give them the answer. Or it's colleagues who work in the trust and they've heard of clinical coding and say, well, we know what clinical coding is, and we know it's important, but actually we don't really know what it means and how it works. And again, you give them the answer. And this is what the answer is. It's the translation of medical terminology as written by the clinician to describe a patient's complaint, problem, diagnosis, treatment, or reason for seeking attention in a coded format. And it doesn't matter which of the two groups that you're talking to, whether it's your friends and family or your colleagues who actually work in the trust, you get the same response from both of them. And it's a complete glazed over look. Because let's face it, that explanation is rubbish, it's garbage, it doesn't mean anything, it doesn't help understand what clinical coding is, and people just stop paying attention when you're talking about coding, when that's how you try and explain it to them. And that largely is the fault of the coding industry. We don't make it accessible to understand what coding is. So that's the purpose of doing presentations like this, is to actually try and clear up that really awful definition and say, well, okay, so what actually is clinical coding? So it starts when the patient is discharged from hospital. They'll have an admission on whatever the trust's PAS system is that is being used, and that admission needs to be coded. So the patient's record, whether it's a physical case note or digital documentation, that'll be sent to the coding department, and the coders will review all of that documentation. Then they will extract all of the diagnostic and procedural information. They'll analyze it, and they'll select the appropriate ICD-10 codes for diagnoses and the OPCS-4 codes for procedures. So how we do that is we read through all of the documentation for that admission. So we read all the doctor's handwriting, as terrible as it is, or all the different bits of electronic information, scan reports and things like that. We translate all of that terminology into your ICD-10 or OPCS-4 codes to get the clinical code. We then verify all of that information against national clinical coding standards and any local coding policies that we might have in place at the trust, and we verify that the code that we've got is correct. And what I mean by translating that medical terminology there is taking all of like the synonymous terms, the medical jargon, and the abbreviations that get used by clinicians, and assigning a standardized, uniform alphanumeric code for that piece of information. So we've got a quick example of what I mean by that here. So you could write a heart attack in quite a lot of different ways, but the three most common that you might find in a medical record is myocardial infarction, MI, or heart attack. They all mean the same thing. It's just three different ways of writing the same thing, but it all gets us exactly the same code. It doesn't matter what way they write it. The coder's job is to cut through those different ways of writing the same thing and get to a standardized code. And what that does then is it makes your coded data comparable across trusts nationally, and then it also makes it comparable internationally if there's another country that is using ICD-10 as well, using the same classification. So that's just makes your coded data a really robust data set for a whole range of different things. So how we do it then? Once we've got all those codes and we've verified the information, we're happy with the code selection, we enter that into the Trust Pass system, and then that data is processed through the national HRG grouper that will apply a tariff in line with the national tariffs and any locally agreed contracting arrangements. And that's how your coding data is submitted, and then your tariffs are assigned and your trust gets paid. So that's what coding is and how we do it. So now we'll look into a little bit more about how the income side of it actually works. So the underpinning methodology, I suppose, is called HRGs. So it doesn't really matter what the payment system is, an HRG is still really at the root of it. So an HRG is a health resource group, and what that means is it's a system where it takes similar sorts of diseases or similar sorts of procedures in terms of how much resource it costs to treat, and it groups them together and applies a tariff. So you don't have a different one for every single different ICD-10 or OPCS4 code, but you have them all grouped together. So there's, as you can see there, there's 2,303 HRGs. And the way they're derived is that every trust submits reference costs, and those reference costs are then analysed and the tariffs are set based on an average. Now, up until the start of the COVID-19 pandemic, the payment system used in England was called payment by results, or PBR, and that did exactly what it says on the tin. You got paid for the work you did, and that's sort of the point that when PBR was introduced, that was the point that coding stopped being a back office function that no one really cared about, to being thrust right into the fore of coding's really important, because coding drives this HRG methodology, which is how we get paid. It wasn't a perfect system, but and there was work to sort of find a better payment methodology. But the COVID pandemic sort of brought that forward. So right at the start of the pandemic, PBR was suspended and all trusts were just being paid on block contracts. As we started to move into a recovery phase, there was a model called the Elective recovery scheme, whereby all of your non-elective activity was still paid for on block contracts, and your elective activity was paid using the standard PBR approach. We are now into a model called aligned payment and an incentive, and what that does is have a fixed element and a variable element to how your trusts are paid. So your fixed element is basically a big block contract for your activity, and your variable element accounts for how closely you meet your plan, basically. So if you carry out more activity than you planned, your variable element kicks in. You'll get paid 75% of the actual tariff for that activity, for basically doing more than you set out to do. And the flip side of that is if you do less than your planned activity, you'll have to pay back 75% of the tariff of that activity that you didn't carry out that you said you would, which sounds quite harsh, and only being paid 75% seems a little bit unfair. The purpose of it is to really get NHS finances into line, and really get a grip of the public purse and public spending on NHS services, and make trusts much more aware of what their actual costs are, so that money isn't being wasted. Although that is the national model that was published this financial year, what I would also say is not all trusts are actually signing up to aligned payment and incentive. So the trust I work in, MFT, we have stuck with the elective recovery programme. Largely, every trust will have different reasons for it. Our reason being that we are implementing a new electronic patient record trust-wide across all 10 hospitals in the trust this year, and it just wasn't felt like it was the right time to change the finance model, whilst we've got all that upheaval going on, because it's a huge transformational piece. So it is worth just checking with your own trusts what the payment model is they're using. But in all of those payment models we've discussed, HRGs are still underpinning those tariff systems, and they're still the logic that's being used to get to the costs. And it's really easy to say, well, you're on block contracts, so the coding doesn't matter. But actually, the converse is true. You've got to renegotiate your block contracts, so you need your coded data to be accurate, so that your tariffs are accurate, so that when you basically is the block contract we're on adequate to actually meet the demands of the activity that we're carrying out, so that when you go to renegotiate that block contract, you've got a solid evidence base to say we need a bigger block contract, because what we're getting currently doesn't meet what we need. Then HRGs are also structured into a hierarchy, a tiered system. So what that means is the vast majority of the HRGs have got a base HRG, but then to recognise the varying complexities of different patients, and when they've got different comorbidities and things like that, it can stay within the same HRG band, but it can move up to a different tier with a higher tariff associated with it, basically to account for the extra resource needed to look after certain patients when they've got more demands. So, like I said, it's not a perfect system due to the tariffs being based on averages, because it could end up where running a service might bring in you a heck of a lot more money than it actually costs you to do. So your service managers are going to say, right, we're going to run more and more of this service, and that might be at the detriment to other services that the local community really needs. The other side of that coin is it might cost a lot more for you to carry out a certain type of activity than the tariff brings in, and what you'd have to do then is sort of build a business case to say, well, it costs us more, but our longer term patient outcomes are better. We've got lower readmission rates, lower post-operative infections, things like that. And once you can prove that, you could then go to your commissioners and negotiate a local contracting agreement to say, yes, this is the tariff, but actually if you pay us more, it will save you money in the longer term because of the benefits of the actual service we're delivering to a higher standard than other trusts are. So how does what is written in the case record influence this? So there's a concept within clinical coding of linked conditions, and the nationally set out guidelines for coders is, look, we aren't allowed to assume a link between two conditions, even if it's really obvious to us just from our own experience. It has to be stated by the clinician in that record that condition A is a direct cause of condition B, or a direct result of condition B, and that can really change the HRG that you land on. So, for example, if a patient comes in and they're noted to have pneumonia and they're also HIV positive, just two conditions, you're going to end up with an HRG that's to do with the pneumonia and a respiratory infection, something along those lines. However, if it's documented that this patient's come in and they've got pneumonia due to their HIV, it's an HIV-related pneumonitis, then that HIV infection is going to be the primary diagnosis with the pneumonia linking it, and it's going to bring you into a whole completely different HRG bracket, which will be one related specifically to the HIV, and that is likely to have a much higher tariff associated with it. So making sure what's written in the case notes is really clear, and any links between conditions is really important, so that the coding is accurate to land on the accurate HRGs. And then get an appropriate tariff back. So the grouper logic for how we get to the HRG that we get to, it's really complex, but it's best understood as Hrgs, the sausage machine. So what we have is a load of information goes in. So we've got our admission method and our length of stay. So with length of stay, there's something called trim points. So each HRG has an expected number of days that patient would be expected to be in hospital for. and that's called the trim point. If the stay goes over that number of days, they will attract what's called an excess bed day tariff. That, by design, is less than the actual cost of having a patient in the bed, and that's so that trusts don't keep patients in for longer to get a little bit more money from the excess bed days. Likewise, it's an easy trap to fall into, because actually if you get that patient discharged and a new patient in, that new patient might bring an HRG that's got a tariff 5 or 10 times higher than the first patient. So it's always worth bearing in mind the trim points. After that, the coded data goes in, the primary diagnosis, any comorbidities and our procedures. They go into the machine, and after the group has done its magic, the HRG is spat out at the end, and that's got a tariff assigned to it. And then that leads to safe and sustainable clinical services. So if we just keep hold of safe and sustainable, I'm going to come back to that in a couple of slides' time. And here's just a visual of the number of HRGs overall. So there's just under 3,000 HRGs, and just under 1,800 of them are tiered. So the vast majority do take account of the varying amounts of complexity within patient groups. And then here, so here's just how that tiered system works. So you've got a primary diagnosis, which will get you your base HRG, and that's the minimum tariff you'll get for that HRG. Add in your comorbidities, and it starts to escalate the income as you move up the tiers. And we've got a couple of case studies that'll be more apparent in as well. So comorbidities, then, I've kind of touched on it a couple of times, but comorbidities are really, really important for clinical coding and for getting to your appropriate HRG and getting the appropriate income. So the medical definition is there on the slide, and then here is the coding definition. That's how it's written in within the national coding standards. So what that basically means is it doesn't matter if it's an acute condition that's just happens to have developed whilst the patient's in hospital, as well as the reason that they've been admitted, or whether it's a chronic condition that they've had for years. They're both considered comorbidities. They both need to be coded, and so it really is, the onus really is on the clinical teams to get that information documented clearly so that the coders can capture it and get the right codes added in. So we can use, when we're coding, we can use the entirety of the patient's medical record for the current provider spell. So that's the date of admission to the date of discharge. So we can use all of the documentation within those 2 dates to make sure we capture all of that relevant information, as long as it's been reported by the responsible clinician. So here's the case study to highlight the importance of comorbidity recording. So if we look in the left-hand column, we've got a patient who's admitted, fairly short length of stay, and they were diagnosed with cystitis, and there's nothing else documented that we can use to code. So this is the HRG that we land on, this LA09Q, and you can see it's got a CC score of 0 to 2. Now what that means is a comorbidity and complexity score, so it's very low at this stage, and that gets us a base tariff of £924. This MFF is a market forces factor, and built into the HRG logic is this MFF concept, whereby all trusts throughout the country have a percentage uplift based on their geographical location. So it's basically just to take account of the different costs incurred for, depending on whether you're city centre or rural or whatever. So MFT, where I work, our MFF is 5%, so we get a £50 uplift. So overall, it's a tariff of £974 to treat this patient. But if we look over here in the middle column, still got the cystitis. The full blood count, the patient had a low hemoglobin. and on the Rockwood frailty score, they'd scored 7. It's now been documented that actually that low hemoglobin, meant that the patient had anemia, and that number 7 on the Rockwood score meant that the patient was frail. So with that's information that we can code, but like I say, it has to be documented as anemia and that the patient's been frail. We can't use the results on their own. So that keeps us in this same LA09 band, but it's changed the Q to a P, and the CC score has gone up to 3 to 5. So that brings us up to £1,838. If we look again, the patient's U's and E's have also come back and shown that the patient was hypokalemic. And now that has been documented as hypokalemia and treatment's been started. And it's also documented that the patient was having some difficulty mobilising to the bathroom, so we've got some difficulty in walking. Again, still in LA09, so we're not changing the banding for the HRG. We're just moving up a different tier to now CC score of 6 to 8, which brings the total cost to the total tariff, to £3,076. So you can see there's a big difference between the 3,000 and the 974. And what I'm driving at here and what's important is that this isn't additional income. We're not finding money down the back of the sofa. It's unrealised income. So the patient always had these 4 conditions here, but they might not have been documented in a way that the coders could use. So the doctors may well have seen the full blood count and seen a low hemoglobin. They've filled in the Rockwood score. They've seen the U's and E's and the potassium's low. But until they document it, and they may well have acted on that information, but until they document it as anemia, frailty, hypokalemia, the coders can't use that information. So it was always there, and it always cost £3,000 to treat that patient. But if that information isn't documented properly so that the coders can use it, we're only going to attract £974. So it's really, really important that that documentation is as clear as possible for the coders so that we can get the appropriate amount of income. So earlier when I mentioned safe and sustainable care, well, HRGs will offer safe and sustainable care only as far as the documentation is reflective of the care provided. And this slide shows the value of procedure recording. So we've got a procedure called a TAVI, so it's an operation to replace the aortic valve. And you can see here is the HRG. It's EY21B with a CC score of 0 to 7, and that gets us £8,450. If it was the next tier up, which would have a CC score of 8+, it'd be £10,500. So that's the range in the tariff within that HRG. And then on this column, we've got a different, we're in a different band now. So it's EY20 rather than 21. Same, just 2 tiers in the HRG. We've got a CC score of 0 to 7 or a CC score of 8+, but the band shifts quite considerably from £10,500 up to £13,500 pounds. And the only difference here between the coding is this 4th character on the Y code. So it's the Y code from a 3 to a 4. So it's just changed the approach to the organ, but it can change the tariff associated with the procedure really significantly. So it's very important that the coders accurately input the codes, and they take care and make sure they haven't mistyped it, they haven't misread it, and that the clinicians accurately document it, as with everything. But there is a lot of responsibility on the coders as well to verify their own work and make sure that they're not making small mistakes of just 1 character. That can be the difference between £3,000 or £4,000. So is it a reasonable assumption that comorbidities should show a consistent pattern? We'd like to think so, but actually it's not the case. we did some research several years ago, and it showed that about 10% of admitted spells were missing comorbidities that we'd expect to be persistent and that would have an impact on income. Excuse me, sorry. So it's all about strengthening that link between coders and clinicians and translating that care, helping clinicians to understand what coders can and can't do, and build that relationship. Research showed that coders are really good at extracting their information and analysing it and getting that information into the system, but the documentation within the case notes and within the various bits of documentation just aren't always up to scratch, whether that's just incomplete, poorly written, or just not written in a way that coders can use. And a large part of that was the clinical disengagement. We've kind of turned that around quite a lot in recent years, and we do a lot of engagement work now with clinicians, presentations similar to this where we explain all the uses of coded data and why it's so important for clinicians to understand it. And we have seen some real improvements in this, and clinicians are buying into it a lot more now and starting to really understand the importance of clinical coding for all aspects, not just the financial side of things. So one of the big things that is important for clinicians to understand when we're talking about clinical coding is the use of terminology. So there's certain terms that we can use. So if a condition is described in any of these terms, then we can assign the code for it. However, if it's described using any of these terms, it's not got enough clinical certainty for a coder to be able to use that. So we wouldn't be able to assign a code for a condition if it was described using one of these terms. And then the next thing is understanding the limitations of clinical coders. So experienced coders are very astute, and they'll have learned a lot over their careers, but we aren't clinically trained. So when it comes to test results, we can't make a decision because it's got to be a clinical decision what that test result means. So a coder may well know that a BMI of 27 means that the patient's obese. They might even know that an ejection fraction as low as 32% indicates congestive heart failure. However, a coder isn't going to know that a raised troponin, whether it's angina or whether it's a heart attack, that's got to be a clinical decision, because it needs training within that sort of interpreting results. So coders can't interpret results. So it's really important that, like I mentioned before with the case study, that if there is a result that the clinicians see, that they document what that result means so that coders can use it. And I've got another case study here to highlight that again. So in this scenario, a lady's broken her leg after she's tripped over the dog at home. She's had surgery, and while she was waiting for transfer, she developed a urinary tract infection due to E. coli, and then she had a series of scans. Then down here, we've got some comorbidities. So we've got a BMI of 34, an EGFR level of 45 to 59. She's a type 2 diabetic, and she's got osteoarthritis of the hips and knees. So all that together, so you've got the fracture due to a trip, the infection due to E. coli, the diabetes, and the osteoarthritis. And here's your scans and your procedure column. So there's your HRG of 1,824. But now in the next scenario, the BMI of 34 has been translated as being obesity, and the EGFR has been confirmed to be CKD3. Both of those are codable conditions, so we can add the CKD code and we can add the obesity code, and it's moved us over £1,000 more in tariff. And again, the purpose of this slide is just to really hammer home that point that this information was always there. We had this information on the previous slide, but it wasn't written in such a way that the coders could use that information to assign a code. So it always cost that nearly £3,000 to treat the patient. But if we can't get the information to add these codes, we're only going to attract £1,800. So we laugh and joke, don't we, about the terrible handwriting of clinicians. And here's an example. I think this was from an endoscopist at Trafford General Hospital. It's a genuine example. This is a real endoscopy report. Coders do have to read actual case notes, case notes with handwriting in, and you do get quite good at reading really poor handwriting. But when it's as bad as this, it's really unusable. And yes, you might pull some information from this the more you stare at it, but you can't guarantee that you've captured everything. You don't know that there's something you might have missed. And it when it's as poorly written as that, the risk that you are missing key information is very, very high. And if we compare it to the likes of this, where we've got a really nice typed up op note into different sections, setting out exactly what's happened, alongside a labeled diagram that the coders can then use to work out which bits are being referenced and see exactly where it is. That really helps them with the code assignment, because you can break it all down and get exactly the right parts of the anatomy. So you can guarantee you're going to get all of the codes that you need in a very, very accurate fashion. So it's really, really key to, even when you can't use digital solutions and have them typed up, that you actually write as clearly as possible in the case notes, so that information doesn't get lost. And it can be as simple as little things between hypo and hyper. If the handwriting is really scruffy, or if you've written it very fast, little details like that can easily be lost, but they have a big impact on the codes, because there usually is a different code for a hyper or a hypo of whatever the disease is that's being classified. So that legibility is really, really important for getting the right clinical code and then getting the right HRG to get the right income. And we can't have a presentation without finishing with a terrible joke. So here, it's not just about bashing doctors and clinicians and saying they don't do enough. Their job is to treat patients. That's their primary function, is to look after patients. It's up to us, all the admin teams, coding departments, finance teams, costing departments, to engage with the clinicians and to explain to them why it's important and what they can do to help us, and then find out what we can do to help them, and work together to improve the coded data set and make sure that the income we get then is reflective of the cost of the care that we're delivering. And that is the end of my presentation. Does anyone have any questions? Feel free to shout out or pop it into the chat. Yeah, go ahead, Alfred.
Hey, yeah, thank you for that. That was really, really good. I had a quick question at the start. You mentioned with the new payment scheme, it's obviously got the fixed component and the variable component.
Yes.
And that clinical coding would be used to help at least work out the variable component. Is that right?
Yeah.
Would that? How would a HRG? Could obviously, when you put the HRG code encompasses numerous different. Say you're in the case of surgery, for example, a couple of similar surgeries would fall under one HRG code, wouldn't they? So
potentially,
how can you accurately track numbers? How can you track targets and stuff based off HRG codes, or would you not? Would you just be going back to the raw coding data?
You'd probably go back to the raw data. So you could look for specific HRGs if you knew that the activity you were carrying out fell into a specific HRG and you were looking for a specific HRG. You could do it like that. And some of them are quite exclusive, but not all of them. But yeah, you'd be better looking at the actual coded data if you were trying to track a specific operation.
Okay, in which case, and then I keep hearing that the national tariff doesn't really exist anymore. In the earlier talk this morning, they were saying that's not really a thing. If we're going back to using the raw coding data rather than HRGs, obviously the tariff is attached to the HRG, not the raw coding data. Is there any, this national tariff, what use does that have anymore?
So if you were looking at the raw coding data, that'll give you the actual volume of that particular operation you were looking for, rather than looking at the HRG data, which might include other operations that have been done. So you just you'd use the coding data to get an accurate figure of what you were looking for. Then you'd look at the HRG associated with that procedure, and the different tariffs depending on the different tiers that it falls into, and then you'd use it like that to get it.
And that would make up the variable component of that new payment model?
Potentially, yeah. So I'll confess I don't know too much about the aligned payment incentive, just because our trust isn't using it, so I've not committed to educating myself overly on it. But yeah, my understanding is that it will still use the HRG methodology and the tariffs associated with the HRGs, but the variable element would be around 75% of that tariff.
Okay, thank you very much.
No problem, thank you. Yeah, Dr. Pagaria.
Yes, hi Sam, thanks for the good lectures. Just to educate myself, I'm a respiratory consultant and head of the lead for the services. My question is more about, the coding is done from the probably, if I know correctly, the first diagnosis made by whoever's seen the patient. The way I'm looking at from the back end is, say our mortality for our pneumonia is very high, and I've been going through the mortality data for last few months clearly, and I'm looking at the way they're picking up is if they're coded as pneumonia, and I'm looking at all of them, and I went through about 50 notes yesterday, and only about 15 of them had the right diagnosis of pneumonia. And looking backwards, yes, there were wordings about treat as pneumonia, possibility pneumonia when they were clocked at the front door, maybe by ED or acute medicine, but maybe a day down the line or 2 days down the line, the diagnosis, when they were seen by the specialist, the diagnosis was changed because something else was happening, but it was still picked up by the coders as the first diagnosis, and it stayed under the pneumonia bracket. So my question is about, should we pick up the initial presumptive diagnosis of pneumonia, or should we work on the final diagnosis at the point of discharge of the patient?
So the answer is going to be a little bit nuanced, I'm afraid. So the primary diagnosis definition for clinical coding is the main condition treated or investigated during the patient's spell of care. So it doesn't necessarily matter if it's the first, second, or 20th diagnosis that's made during the patient's stay. It's whatever was the main condition being treated. Now, where it becomes a little bit more complicated is how a spell is broken down into episodes. So your spell is the point of admission to the point of discharge, and that is then punctuated by what's called a finished consultant episode, an FCE, and that's sort of every time the patient is transferred to another consultant or to another ward, or another specialty, I should say. They're usually the things that trigger the start of an episode. So each episode could have a different primary diagnosis, because it would be the main condition treated or investigated during that episode. So if they have a very, very short episode right at the beginning in ED, maybe a day or two, then they might have a completely different diagnosis to once they're up on a ward and they get a diagnosis from a specialist. When you're talking about mortality, it becomes a bit more complicated because the mortality methodologies only ever look at the first 2 episodes in a spell. They won't look beyond that to the subsequent episodes. So if you've got a lot of episodes within a spell, those first 2 can often not have an accurate diagnosis just because not enough time has passed for the patient to be reviewed by a clinician to get a confirmed diagnosis. Does that make sense?
Yes, it does. So probably that's the reason the mortality for pneumonia is skewed, and we are always showing that the ischemia is so high. But if we dive into the notes and look at it ourselves in details and exclude the ones which probably the working diagnosis, or you can say towards the end of towards the middle or end of their stay in the hospital has changed their primary diagnosis, but then all the numbers start to look better.
Potentially, yeah. I can't really say without seeing the data myself, but yeah, that sounds about right.
Yeah, no, I can. But is there any way around it? Is there, or is that the way the mortality data has to be coded, or can I go back to the coding people and say, look, you need to look at it differently?
It's worth having a conversation with your coding team and trying to find out what their processes are, and if there's anything that can be done, whether there's a validation exercise that needs to be done to look at the patients that are flagging as outliers on your shimmy, and basically do a case note validation exercise where you look through the case notes and make sure that the primary diagnosis is accurate, or whether they're not quite capturing the right primary diagnosis.
Okay, thank you very much for that.
No problem. Any other questions from anyone? Mortality or finance, I don't mind.
I've just got a broad question. I suppose and then maybe it's also a question to some of the clinicians on the line, but what have been, from your experience, Sam, the approaches or strategies that have worked to support the clinical teams with doing some of the things that, you know, can be quite, when they're under pressure, can be quite challenging to achieve, but obviously have quite dramatic implications when, for example, like you say, if there isn't an explanation as to what a observation or a result is, then we're then not getting the funding for that. So I suppose it's probably a question to you, but maybe also to some clinicians who may be on the line as to what you'd find helpful. I'm a service manager at Great Ormond Street, so I want to support my clinical teams as best as I can.
So at our trust, we've done a few different things in terms of sort of validation. A lot of it comes to doing post-coding exercises when you've got a bit more time to go back over the data. And so we've got quite a few local coding policies in place. They can be a little bit controversial, local coding policies. So just to bear that in mind if it is a route you decide to go down. But one of the most effective ones that we did was we got the clinical team to validate a series of biochemical markers, so blood test results basically, and to confirm the reference ranges that would indicate a diagnosis of a hypo or hyper of that particular marker. Then we worked with our labs team using the Hrgs database to, after all the coding had been done for that month, we would exception report all the blood results. So where those criteria were met that were signed off in the local policy for the reference ranges, but the codes weren't added, they would be surfaced, and then we can send that out to the coders after the coding deadline, after the flex deadline, before the freeze deadline, to revisit the coding and add those codes on for the hypo and hyper various blood disorders. I can't think of the right words, but yeah, do you know what I mean? So that has been a really effective one of capturing those and sort of mitigating where clinicians don't always write what a blood result means. So that's been a really effective one. Another one that we did just on one of the sites in our trust, it was a few years ago, it was before we sort of merged with a few of the other trusts, it was more of a case mix reason, but it has got a financial implication as well. So we found that a lot of comorbidities weren't being recorded consistently. So we developed a program called, it's a database that stores all the codes basically that are entered for each patient. It's a bit of a reference database. When the clinicians are writing their discharge summaries, there's a direct feed to that database, and it will surface those codes that have been previously recorded, and the clinician can then validate them and say, yes, that's correct, yes, it's still relevant, or no, that's not relevant. Those codes are then displayed on the discharge summary, so the coders can see those codes and they can take it as it's been reviewed and validated by the consultant as present and relevant, and they can add those codes on as well. So it doesn't matter if it's been missed from being written down in the case notes, they can see it on the discharge summary that's there, and they can add the codes in as well. So that did a really great job of bolstering our case mix. and a secondary effect of that was it boosted income as well.
That's really helpful to share. Thank you.
Yeah, no problem. I'd also add that harp on as much as you can about the value of comorbidities. Comorbidities are the almost low hanging fruit, but the big ticket item at the same time. It's where the battle's lost and won for sort of getting that escalated income on your tiered HRGs, for getting the higher scores on your mortality metrics, for strengthening your case mix and all that sort of stuff. So as long as you can push that message of comorbidities to everyone.
Thanks again.
I would just like to highlight that we teach our junior trainees who come through about clinical medicine, but we never teach them about coding. It is so important the way they document the post-take ward rounds and the ward rounds and how they're clinically documenting it. So I'm trying to see if we can get one of our coders to come in within the first couple of, maybe first month or 2 months of the foundation training trainees starting in the hospital, for at least them to understand how important it is and where do the coders pick the data from.
Absolutely, yeah. I'd always advocate a really strong standing program of engagement for junior doctors, and get it into them as early on in their training as possible to understand what coding is and why it's important and what their responsibility is in that process. You obviously need to educate your consultants as well, because they're the ones sort of instructing the juniors, but the juniors need to have that base knowledge as well.
The consultants are the difficult ones to I think the juniors are easier.
Alfred?
Yeah. Hey, sorry, could you just repeat? Did that system you said where it would flag up past comorbidity codes on discharge? Did that have was that just in Manchester? Does that have a name?
Yeah, it's one that we built ourselves in Manchester, so it's called Code Miner, but it was an in-house build. It's what I would say and caution against it is it's very much not a perfect system. The implementation of it here wasn't brilliant. It served its purpose, but we are now in the process of deprecating it before we go live with our electronic patient record, because we don't think we'll need it anymore.
Okay.
So it's definitely something to consider and maybe replicate of a fashion, but I wouldn't recommend our model exactly, because it has got flaws.
How transferable are techniques that say it was better, say it was a near perfect system? How easy is it to then transfer it to other trusts and other clinical coding teams?
Honestly, I wouldn't know. It was implemented when I was not long started as a junior coder, and I don't know which technical teams were actually involved in the building of it. So I can't answer that, I'm sorry.
Okay, thank you.
Any other questions?